Hello everyone, and welcome to today's webinar, Trauma Verification's May Q&A Web Conference. My name is Sarah from GoToWebinar. Before we get started, I just want to go over a few technical details so you know how to participate in today's event. You have joined the presentation listening using your computer speaker system by default. However, we do recommend that you join over the telephone for the best audio clarity. To switch to telephone, you can just select phone call in the audio pane of your GoToWebinar control panel, and the dial-in information will be displayed there for you. You are in listen-only mode. This simply means that you are muted so we don't pick up any noise from your end. All right, without any further ado, I would now like to introduce Molly Ladoza, Trauma Verification Program Manager. Welcome, Molly. You now have the floor.
Thank you. Thank you, everyone, for joining today's webinar. It's going to be just me today going over site visit information and the CD-related questions. To qualify for CE, you must attend at least 50 minutes of educational content. An email will be sent to all attendees who qualify for CE within 24 hours of the webinar ending with instructions on how to claim CE. If you have any questions during this presentation, please email us at cotvrc@facs.org. The goal for today's webinar is to interpret the standards outlined in the Resources for Optimal Care of the Injured Patient Manual to ensure that hospitals have an understanding of the criteria to provide quality care to the injured patient, understand the processes and standards involved in an ACS trauma verification site visit, and how following these will positively impact the quality of care of the injured patient at your facility. So with that said, we're going to go ahead and get started. As many of you are familiar, but for those of you that are new to our process, this is a copy of the Orange Book. There is a PDF available online that you can download at no additional cost. I do advise that when you do use the resources manual, whether hard copy or PDF, be sure to download the most current version of the clarification and verification log, which is currently posted on our website at the link noted below. And again, these are just screenshots of what the documents look like, and they're released monthly. We're going to release another update here today, sometime either today or tomorrow with the latest changes. And again, these are available on the website. This is just a resource for trauma centers. We have the recordings of the webinars. There's a new location for those just in case you're looking for them, so please make note of it. The stakeholder public comment website is still open. Frequently asked questions, there's a short list of questions that are available to you and tutorials for new trauma centers or even trauma centers that are preparing for a site visit. There is a new tutorial that you can view. And also the Participant Hub Account Center, where you will log in for existing trauma centers, that is, TQuit centers and verified trauma centers. You have logins that you can manage your contact information on this web Participant Hub, that is. All questions are pulled directly from the questions submitted. There have been no edits made to the contents. If your question is not answered today, the question may require more information and will receive a response from the ACS staff within the following week. Just a quick announcement, and I'm sorry I did not bring this up earlier, but our next webinar is June 26th. It's scheduled for June 26th from noon Central Standard Time, and the deadline to submit questions is June 13th. We're going to go ahead and move on to scheduling reminders. Site visit application, as many of you know, there is a lead time for this. If you're not familiar with that, please visit our VRC webpage. So again, it's 13 to 14 months regardless of the type of site visit. The only one we have an exception for are on-site focused visits. Those are, our policy is that we have to schedule those within a year following their site visit, so we do accommodate for those. In addition, Level 1 trauma centers, be sure to complete your orthopedic trauma liaison form. If you've completed one in the past, no need to complete another one. And again, if there's any trauma centers out there that have any providers, physicians, surgeons who are not boarded in the U.S. or in Canada, there is an alternate pathway process that they would have to be reviewed by, and there is again, there is a process for that, meaning that if you know at the time of your submitting your application, we would need a copy of their CV along with some additional information that Rachel can reach out to you for. And they are still accepting applications for visits, scheduling visits February 2019 and the rest of 2019. So everything for this year is closed up to January of 2019. Again, just want to make a mention of how important it is to provide us new contacts if there's been a change in your trauma center with the trauma program manager, the trauma medical director, or your CEO or your president. We realize that when you're submitting the application, it's 13, 14 months ahead, and a lot of things can happen within that time. And we do realize that. So if there was a change during that time, we would greatly appreciate you updating that on the participant hub, or you can email us and we will update your contact information at our end. And again, it just goes into some areas of why it's important to provide us your contacts. Otherwise, we have the wrong contact information on the letters and reports that go out to you. And on the applications, I think many of you have been doing this. We do want your credentials on this because, again, the credentials help us with addressing the letters and the reports and making sure that we have the appropriate information. PRQ that is provided to the trauma program manager at the time the application is submitted. There may be a couple of days of lag only because Anita will receive several at one point, and she has to process each individual application and has to set up each individual PRQ. So if you can give her a week to set that up, then you should receive your access to the PRQ shortly thereafter. In the meantime, there is a copy of the PRQ in Word that you can download, and it does. We have checked this. We have verified this, that it matches the online version. And we are going to have a segment probably starting in the next couple of months related to PRQ changes. If we make any changes on the PRQ, we will make that known here on this webinar. Again, just a reminder, site visit application, don't submit any payments. Your center will be invoiced. Everything is shifted to an annual fee. And there's a fee link that you can view to determine what that fee will be. I know budget's coming around, at least it's coming around for us. So I know many of you are working on your budget. So please take a look at the fee structure on the webpage here. And this is just about scheduling visits. Rachel's doing them on a quarterly basis. We've kind of transitioned a little bit to she does them on a quarterly basis, and also she's moved towards exact dates. And if she doesn't have an exact date from your trauma center, what she'll do is she'll reach out to you and just ask you for several dates. It seems to be working really great for our process and also for the reviewers. They actually welcome knowing exactly when the visit's going to occur, the same with you all, and it is helpful to know when your visit's going to occur so you can schedule folks and the meeting rooms and so forth. And again, she's got on here that visits will be scheduled within 120 days. I think she's actually within 90 days, or actually well within 90 days of that. Again, just a reminder that reviewers will arrange their travel with the ACS travel agent. If you have an upcoming site visit and have not heard from your reviewer or review team or the lead reviewer, I encourage you to reach out to them just to see what their flight arrangements are, so then they don't just appear at your trauma center unexpectedly. So I would just reach out to them, introduce yourself, and just ask them if they have an arrival time or a start time for the site visit, so that way you can plan accordingly. Again, accommodations will be arranged by the hospital, and again, their ground transportation also, if you can arrange for that, or if it's quite a distance from the trauma center, you can ask them to either rent a car or I don't know if I want to say Uber, but you can have that conversation with the reviewers at that time. Just a quick note to those folks that are preparing for a site visit and are working on their PRQ, and this is for participants and reviewers. We will be doing a schedule maintenance on the Account Center Hub and the Trauma Survey, which is Survey 5, which is the PRQ. That will start this Saturday, June 2nd, from 3 p.m., and they have informed us that it will most likely last through Sunday, June 3rd through until 10 p.m. It may be sooner than that, but that's the time frame they've given us. So I just want to prepare you guys that if you're working on your PRQ over the weekend, to just make a mental note that it will be down. So if you don't save what you currently have, you will lose that data. But if you don't access it during these hours, you'll be fine. But it'll be back up sometime Sunday. So you can check the Trauma Survey PRQ link during the day, because I think we're going to kind of test, or I'm going to test it Sunday afternoon to make sure it's back up and running. Just a short announcement, and I should have probably done this back in March. I just want to introduce to you all our VRC chair. Dr. Daniel Margulies is my chair, and Dr. William Marks, also known as Bill Marks, is my vice chair. So I just wanted to make those known to you all. And then we're just going to move on to general questions. Question about how many months of trauma data are needed before submitting the application for a consultation visit. For consultation and or verification visits, and this also applies to re-verification visits, the trauma center must have 12 months of data in the registry. Of course, for those new trauma centers for consultation or their first time verification, an application may be submitted while the center is collecting the data for the upcoming visit. So there's going to be a little lapse in there. Oops. Trauma center relocation. This is becoming a little bit more frequent. Our level 2 verification goes through spring 2021. We move into a new medical center in the fall of 2019. Everything will be the same or enhanced: staff, providers, equipment. The only thing changing is the physical address. What is the process for verification at that site? A complete verification visit, a focus visit, how does that work? Great question. So the way, or our policy is, if the trauma center or program moves from its current physical location, as this trauma center will be doing, to a new location within 12 months of having its verification visit, re-verification, or focus site visit, any of those, a walkthrough, what we call a walkthrough visit, will be required to verify that everything has remained the same, that, you know, the staffing's there, the equipment, the operating suite, emergency room, the providers, etc. So if you have, if the move occurs before your visit, then there's no need to have what we call this walkthrough. But if the move happens shortly after you had a visit, then we're asking that occurs within the 12 months of that. Research: what is the difference between a multi-center and a multi-system project? The multi-center and multi-system language or terms are used interchangeably within the verification program. I do realize we have it, I think in the book it's called multi-system, and I think through some of my webinars it's called multi-center, and then on the form we've also clarified that we use the words interchangeably. The intent is that if the trauma center is or will be involved in a multi-center research project, that it must involve trauma surgeons and data from its facility in the collaboration with the other trauma programs. So if you are in a multi-center research project within 3 facilities, 2 facilities, or how many that may be, that you have to ensure that the trauma surgeons from each of the different facilities, along with data from the different facilities, are being used in this multi-center or multi-system project. And we have started verifying the research components. So for those level 1 trauma centers, we have reached out to you and asked you to fill out the form and return that to the office, and we are verifying that that information is accurate, and we do relay that information to the reviewers. OPPE documentation for the verification visit. Do we need copies of the OPPEs for emergency medicine, neurosurgery, ortho, and ICU? We're not asking for this documentation to be available for all your panel members. What we're asking for is, the first question there that the reviewers ask is an OPPE being done on all the panel members? And if so, what that process entails. And what I would recommend is having a copy of what your OPPE template looks like so that reviewers can see that. Maybe not just a blank template, but have one completed and just have it available for each of the services for the reviewers. PRQ guide. What is the VRC doing to improve the clarity of the PRQ? We found it very vague and hard to interpret. We got things wrong. The PRQ is ambiguous in places. What is being done to make it more clear? We got a few questions on our PRQ, and I think I've mentioned, either I have or Tammy has mentioned in earlier webinars, that we are currently in an ACS-wide process or project, if you will, in streamlining all of our accreditation program and verification program PRQs. So we are working on that. We're hoping to have something available early next year, if not early next year, sometime next year. Again, we're very hopeful that that will come through. So in the meantime, what we are doing is any feedback we receive from the participants and reviewers, for that matter, we do take those recommendations and we implement them in our changes and updating the PRQ. The challenge is that, it's a programming aspect. We can't do them all at one time, and there's a lot of testing that is involved with this. As you can imagine, there's 10 variations of trauma centers and levels that we have to go through. So we are doing them as quickly as we can. So in an effort to assist trauma centers in understanding some of the ambiguous and vague and difficult questions or standards, what we have done is we've developed this PRQ guide, and that PRQ guide is not listed on our website, but it is available to all trauma program managers or registrars, whoever wants a copy, and it is released with the application acknowledgement from Anita. So she sends this out to the trauma program managers. If you have not received a copy of this guide, please email us and we'll make sure that you get one shortly. PRQ antibiotics. We had a question about is there an appropriateness and timing of intravenous antibiotics for all open fractures? And I believe this is on our clarification document. If it's not, I'll go ahead and add that. So the current recommendation from the committee, from the verification committee, for the time for the first antibiotic administered for an open fracture to the trauma patient that arrives in your emergency department is 90 minutes. Any times beyond this or that exceeds the 90 minutes will be cited as a weakness in your report, so you may have seen that with a recommendation. So right now, the recommended time is 90 minutes. Trauma liaisons and certifications. We had a question about additional certifications for the trauma liaisons, whether it's critical care or BCLS or ACLS or PALS. For all trauma centers, the trauma surgeons are required to have taken the ATLS course at least once. That is a requirement. For all other specialists, the BCLS, ACLS, and PALS are not required for verification. However, I just want to stress that your individual institution may require the additional certificates as part of their credentialing process, and you may need to look into that during a site visit. That may come up as a question. If you are verified as an ACS Level 3 and have a Level 2 verification visit after, does the Level 3 verification stay in effect if the Level 2 is not passed? That's how I'm reading this. So it does not. So if the trauma center that is currently verified, for example, as a Level 3 and requests a visit at a higher level, as in this example, as a Level 2, and it does not pass the Level 2 verification, the trauma center will no longer be verified. So it forfeits the verification for the Level 3 because you requested to be verified at a higher level. However, if the trauma center met the Level 3 criteria at the time of the visit, a written request that is signed by the trauma medical director and the CEO may be submitted to the verification review committee requesting to be verified as the Level 3. So it's all a matter of whether or not the trauma center met the standards for either the Level 2 or the Level 3 at the time of the site visit. It does not require an additional site visit. It's just based on whether the criteria were met. Advanced practice providers are APPs eligible for the shortened recertification ATLS course, or must they attend a full 2-day course each certification cycle. We have confirmed through our ATLS team that the advanced practice providers and or physician assistants are welcome to take the ATLS student refresher course, and that would meet the requirement for maintaining current in ATLS. CD-related questions. Is there any consideration to dropping the volume to 1,000 versus 1,200? This is in regard to the Level 1 criteria for trauma centers. For Level 1 trauma centers that must maintain a 1,200 trauma admission volume. There have not been any discussions on revising this criteria. I haven't seen any come through the stakeholder comment website either. We have not yet started working on Chapter 2. We have assigned a Chapter 2 to a work group, and they will be revising that. And again, I don't recall seeing any discussion about the volume criteria. So what I would recommend is if you have not already done so, you may submit your recommendations with supporting literature through the stakeholder public comment website noted here on the webpage, and then they can review that and take that into consideration if they want to revise that number. Does diversion include redirection as well if the hospital tells EMS that we still accept trauma when we are on redirection? I know it's a little wordy, but my understanding of this question is bypass or diversion. Again, we use that word interchangeably for the person who asked the question. When we talk about bypass or diversion, they mean the same to us for verification, and it is based on when the trauma center will not accept trauma patients from the field. So if you're redirecting patients, diverting patients from the field, then that definitely will count towards your bypass or / diversion rate. Question about non-surgical admissions. This is a little long, but basically the person is asking us to clarify programs that admit more than 10% of injured patients to non-surgical service must review all non-surgical admissions through the trauma PIPS process. I covered this in the March Q&A, that a non-surgical admission was a patient who was admitted but did not have surgery, which is correct. It would also be assumed that a non-surgical service would be a physician service group that does not perform surgery, and that's not necessarily correct. It could be one or the other. Our program has been reviewing patients admitted to a non-surgical service, but our trauma ortho neurosurgeons often admit patients that have a traumatic injury but do not require surgery upon secondary assessment, family consultation, or complete workup. That's acceptable. That is definitely appropriate to do at your facility if those are within your policy guidelines. Based on this CD, which patients are subjected to PIPS review? Patients admitted to the non-surgical service or patients admitted to surgical service but do not have surgery, or both? It's both. So the answer to this is if you're following the algorithm on page 121 about the non-surgicals, where you're following that table that's on there, if the remaining, because remember the CD is not based on the center not having greater than 10% non-surgical admissions. The CD is in regard to if you do have greater than 10%, is the trauma center reviewing those greater than 10% non-surgical admissions, and whether or not they had a surgical consult, and if they didn't have a surgical consult, were they reviewed through the PIPS process to determine why that didn't take place? So that really is where the deficiency lies. And again, so if you follow the algorithm on page 121, if the remaining patients are admitted to a non-surgical service and did not receive a consult by one of the surgical services, being trauma, ortho, neuro, what have you, those patients are subjected to be reviewed. And then also you want to make sure that you review those through your PIPS process and document as to why they may have not had a surgical service or surgical consult. If only PEDS board certified versus emergency medicine board certified, can they care for trauma patients, including trauma activations? So again, this is also this is for a level 1 trauma center, and the following question is related to a level 3, so my response is going to differ, because as it states here, for a level 1 and 2 trauma center, physicians who completed primary training in 2016 and after must be board certified or board eligible by the appropriate emergency medicine or pediatric emergency medicine board according to the current requirements. So anyone who has completed their training in 2016 and after has to be board certified in emergency medicine or PEDS, EM, for a level 1, level 2. If they've already been working in your facility prior to this, they're fine. There's nothing they need to do other than maintain current ATLS. That is a requirement across all levels. Physicians who completed primary training in 2016 and after, who are not board certified in emergency medicine or pediatric emergency medicine, they, again, can work in the emergency room but cannot participate in trauma care. So the difference here is that 2016 date. The following question is, again, this is from the level 3. ERMD who graduated after 2016 that are not ER boarded, can they take care of ER patients and not trauma, or is this a deficiency? So again, the standard prior to this was for level 1, level 2, for level 3 trauma center physicians who are not board certified or board eligible by the appropriate emergency medicine or pediatric emergency medicine board, but are board certified, say, in family practice, internal medicine, pediatrics. They may provide trauma care in the emergency room. They may be part of your activation team. The only stipulation to this is that they must maintain current status in their ATLS, as mentioned in the prior slide. The 2016 primary training language, again, as mentioned in the prior slide, does not apply to level 3 trauma centers. This will not be cited as a deficiency. Neurosurgeon, a question about neurosurgeon in level 3 center. In a level 3 center, I am dropping to 1 neurosurgeon in July. Please explain a call and backup requirements. So a level 3, so as many of you know, level 3s are not required to have neurosurgery capabilities. So if you read the book, it really pertains to level 1, level 2. However, if you're a level 3 trauma center that does provide neurosurgery capabilities and has neurosurgery, what you want to do, if you're dropping to one neurosurgeon, you definitely have to have a contingency plan. And what that plan includes is a process for by which the trauma center is going to credential the trauma surgeon to provide that initial neurosurgery evaluation and stabilize the patient and ship the patient. So again, that could be part of your contingency plan, or have a transfer agreement with a similar or higher level verified trauma center that is able to care for the neurotrauma patient. And then also ensure that there's direct contact with the accepting facility when you're transferring to ensure ongoing monitoring support. And also you want to monitor all these instances through your PIPS process. So if you're level 3 with that provides neurosurgery capabilities, you want to make sure you have a contingency plan in place, not necessarily just for having one neurosurgeon, but if that neurosurgeon is tied up with a patient, then at least you have a backup plan to stabilize the patient and transfer the patient as needed and not delay care. Orthopedic backup call schedule. If there's 24/7 orthopedic trauma call, does a hospital need an orthopedic backup call schedule, referred to CD 9-5. So to clarify, the backup call system is not necessarily a schedule, but it can be a schedule, but the way the book reads, it's a backup call system is a CD 9-6. A backup call system is not required if the program has dedicated orthopedic surgeons on call at all times. So the way the requirement reads, and I know it's a little vague as well, is that you either have to have dedicated orthopedic surgeons at the facility. If you don't have dedicated orthopedic surgeons at the facility, then you have to have an effective, what they call an effective backup call system. So you have to have something in place in the event that a patient comes in needing an orthopedic consult. And that system can be a backup call schedule, it can be a PA, orthopedic PA responding, it could be a resident, that's going to vary at your facility. Pediatric Trauma Program Manager, what are the FTE requirements for a Level 2 Pediatric Trauma Program Manager? A Level 2 Pediatric Trauma Center must have a dedicated trauma program manager. Depending on the patient volume of that trauma center, the Pediatric Trauma Program Manager can also serve as the Pediatric Registrar or the Pediatric Injury Prevention Coordinator. Not all three. They can do the TPM, be the TPM, TPM, or the registrar, or the TPM and the injury prevention. What we worry about is that if it's a high-performing Level 2 trauma center, there's a lot of them out there that are very high-performing, like a Level 2. If the volume is pretty high, the reviewers may cite it as a weakness if they see that the trauma program manager is doing the two, is functioning, as the registrar and also the trauma program manager. And also, that may also impact the registrar criteria, where it's 500 to 750 admitted patients. Again, there are some high-performing Level 2s out there, so you want to look at that carefully on your volume numbers. Continuous rotations in trauma for residents, PGY 4 and 5. Does this include general and ortho surgery and emergency residents? So the way I understood this question is whether a continuous rotation needed to have all three services, and the answer is no. The continuous rotation requirement is for trauma surgery. That's how it reads in the book, and anything additional to that, any additional postgraduate training, education may also include ortho or emergency medicine, acute care. It can include any of the other surgical services in the residency program, but it doesn't need to be all three. The continuous rotation is for trauma surgery. Can you please clarify what is meant by CD 1114? It states an operating room must be adequately staffed and available within 15 minutes at a level 1 and level 2 trauma center. Does this mean the patient must be in the room within 15 minutes? Can you provide any options for tracking the availability and staffing of an OR within the time frame? So the expectation is that the operating room team is notified when a trauma patient is going to be sent to the operating room. So so within 15 minutes, that's when the team has to be there so that they can receive the patient. The initial call and the team member's response must be tracked, and that can be done various ways. It can be done with a logbook, by EMR, or by batch swipe, and then you can print out a report and monitor any delays through the report process. Is the interventional radiology requirement referring specifically to embolizations? It refers to all interventional procedures. That's the way it's written in the book, which may include embolization. So any procedures involved with that, it's going to be included as part of that. CD 11-33 states that for level 1 and 2 center, a qualified radiologist must be available within 30 minutes to perform complex imaging studies or interventional procedures. It is too vague and non-specific enough to hold IR responsible. If it takes 20 minutes to reach and speak with the IR attending, technically the clock does not start until communication is established. However, care is delayed during that time. The word available leaves too much to interpretation. It does not say in person. As such, the IR attending can say they were available within 30 minutes by phone. Please advise at next VRC webinar. So the way this reads and the way it is interpreted by the reviewers is that the criteria reads that the IR, interventional radiologist, must be available, meaning respond within 30 minutes to perform, which is in person, complex imaging studies or interventional procedures. It's not a phone conversation. They have to be at bedside in person. The clock will start when the call is made that the case is going to go to the operating room or when the patient will be taken to the operating room. So if there's a discussion being had or conversation taking place before the decision is made to take that patient to the OR, that does not factor into the time unless they're having some other kind of discussion outside of the time frame. So again, the clock will start when the call or the decision is made that the patient will be taken to the operating room to perform the procedure. We had a question about hospice in reference to CD 16-6. Please clarify, patients transferred to hospice care should be reviewed as death. When a patient is discharged from a hospital alive to hospice care, are we supposed to review these patients as a death even though the patient is alive? If so, how do we PI a survivor as a death? I realize there's been a lot of questions about a hospice and whether or not that's a death and should that be reviewed as a death. Really what we want the trauma center to do is if the patient was transferred to a hospice service within the hospital or a hospice facility outside the hospital, the expectation is that the care leading up to the transfer is evaluated through the PIPS process by the trauma medical director and or the trauma program manager. If there are any issues found with the care, then that can then it can be reviewed at the peer review. And going back to if it's a hospice service within the hospital, you would probably know if that patient died, and then again you can review that. We're not saying that you have to review that. We're asking that if it happens that you at least review that the care leading up to that death. There's no CD around the hospice patient not being reviewed, so I just want to make that clear. Do advanced practitioners need to attend 50% of trauma systems and M&M meetings, committee meetings, even if per diem? I do want to clarify, and at the bottom I made a note that I am taking M&M, I'm using M&M and peer review interchangeably. I wasn't sure if they're calling their peer review M&M, which is okay. Some centers do call it M&M, and they have different names for it. Advanced practice providers are not required to attend the trauma systems and or the peer review meetings or / M&M meetings. However, based on institutional guidelines, they may be required to attend the trauma systems and or the morbidity and mortality meetings. So if they have to attend, that's probably based on your institutional guidelines, but based on verification process, they're not required to attend either of the meetings. On admission, patients are asked about alcohol use as part of this nursing, part of the nursing admission history. Is this sufficient screening to meet the requirement of screening 80% of admitted trauma patients? I probably have a little bit more follow-up questions for this person, and I think it's a little different than what we're asking, but our answer, and this is again is in the clarification document, is it is applicable to eligible patients that being alive and participatory, regardless of whether or not they were activated or non-activated, who meet inclusion criteria with a hospital stay greater than 24 hours, who are admitted to the hospital and are entered into the registry. So if that's part of the process to admit them and enter them to the registry and they're there greater than 24 hours and meets the criteria, then that would meet the 80% threshold. And again, these include activations and all admitted trauma patients, including orthopedic and neurosurgery services. So we're going to cover CME, and I know I released a couple of documents, and the last document had to do with what I'm going to cover today, and there are a few questions that I did keep in here, only because I know some folks submitted them because they were relevant to their trauma center, but I do want to let everyone know that there are some questions that I kept only because I want to make sure that I did answer these particular people for what is relevant at their trauma center. So as many of you know, we've changed the CME language in our last newsletter that went out, I believe, a month ago. And the change that came out of that is that we changed from 48 hours to 36 hours just to make it an even number, so that would be 12 a year, and that is only applicable to the trauma medical director. So we are only asking for the trauma medical director at level 1 and level 2 trauma centers, and the pediatric trauma centers as well, pediatric trauma medical director, to have external trauma-related CME. So in level 1 and 2 trauma centers, the trauma medical director must fulfill this requirement by obtaining and demonstrating, meaning having their CME certificates, a minimum of 36 hours of verifiable external trauma-related continuing medical education over a 3-year period. Again, that could be done 12 a year or as many as you want in 1 year, but as long as there's 36 leading up to a site visit, then you're within the requirement. And again, it's the same requirement for the pediatric trauma medical director, with the exception that 9 hours of those 36 must be specific to pediatric trauma. That is the only difference. For the trauma surgeons, pediatric surgeons, specialty panel members, that being your liaisons, that being your other non-liaisons, all the other trauma panel members, emergency medicine, neurosurgery, orthopedic surgery, ICUs, who are participating on the trauma call panel, maintaining their current boards satisfies the CME requirement. We're not asking for MOC. We're not asking for copies of their CMEs. We're asking that for all your liaisons and non-liaisons, that they maintain current boards, and that is a requirement outside of this. That is a requirement within our guidelines, that they have to be current in their boards. And again, in other words, if all trauma panel members are current in their respective boards, again, ortho, neuro, emergency, ICU, it satisfies the CME requirement at this time. And the other component to this is that the trauma medical director is expected to assess the individual surgeon's adequacy of trauma care knowledge in ongoing professional practice evaluation, which is the OPPE process, and retains the right to require additional CME or internal education process that stems from the Trauma Center's performance improvement and patient safety process. For the specialty panel members, emergency medicine, neurosurgery, orthopedic, and ICU, the OPPE may be done by the specialty liaisons with approval of the TMD. So what this means, and I didn't put this on the slide, but what this means is that because we're not asking for CMEs, we're not asking for that, we're not requiring that at this time for the other panel members, that if during the OPPE process there is an issue with care, there's an issue with a trauma surgeon or with something that resulted in a system issue, or something wasn't done right or appropriate, that the trauma medical director can impose having that particular service or that particular panel member do internal education or do some external CME. So if that's the case, then they will require to have external CME or a combination of external, internal, or through an IEP process. So that's really what that language means. And then, of course, we have some clarification already with the CME language, and really it's to make it a little bit clearer, because we're talking about residents, recent grads, and lifetime, what we also refer to as grandfathered board certification physicians/surgeons. They are not required to do external CME, internal CME, or IEP. Since they're recent grads, they're technically eligible for certification, and the grandfathered members are also, as it is, grandfathered in, so they are current in their board, so they don't have to do anything differently than the other panel members. The other exception to having someone have external CME is anyone who's gone through the alternate pathway. So if you have someone who is going through it, or someone who has previously gone through it and was approved, they have to maintain external CME, either external, internal, or through an IEP process. So that's what that second bullet refers to. And also, as I mentioned earlier, updates to the PRQ, we are working on those, and it does involve programming. So we will, once those changes are made, I will make that announcement in the next webinar or through an email distribution. So I'm just going to cover a couple of questions that came in, and again, these are very specific to some trauma centers, and I just wanted to take the time to answer them. So we had several questions on MOC. I just pulled a couple here. I listed them on here, and I do realize there was a bit of confusion. We released one newsletter that referred to MOC, that we were going to collect MOC, but in the midst of releasing that newsletter about MOC, we got word from the American Board of Surgery that they have shifted from MOC to what they are calling continuous certification, and until all the other specialty boards shift in their policy, we have dropped the MOC piece of it. So we are not collecting MOC documentation or verifying if the providers are actively enrolled in MOC. We are not doing that. We're not going to impose that on you, because that is a lot of work. At this time, maintaining current board certification satisfies the CME requirement. So that really is what we're asking. How do we best demonstrate physicians' compliance with maintaining board certification according to the new CME criteria? Great question. What we've been telling folks is to demonstrate compliance with the change in the CME is making sure that when you are completing the appendices in the PRQs, there are several appendices, as you see here, 1, 2, 4, 5, 6, 7, 8, 9, 13, and 14. These are for the trauma medical director, your liaisons, your trauma surgeons, your ortho surgeons, your neuro ortho, emergency, and ICU, whoever's taking ICU. So all your trauma panel members have an appendice that would tie back to them. So what you have to make sure is that when you're completing the appendices in the areas where it asks for board certified, the year of current certification, what we're really wanting is their expiration date. So make sure that you enter what their expiration date on their certification is, or what their boards are valid through. So if you put something, if you happen to put when they first received their boards, it's a red flag for the review, and right off the bat, they'll flag that as a deficiency. So I just want to make that clear that you want to enter the expiration date. And then there's the appendice number 2, I believe, and a couple others that may have a column dedicated to CME. Just leave it blank unless it's someone who went through the alternate pathways. Then you do want to document their CME hours in there, but otherwise you're going to leave that column blank. CME, TMD, and alternate pathway, again, in addition to the trauma medical director, the specialty panel members need 36 hours of CME. No, they do not. As I mentioned, external CMEs are only applicable to the trauma medical director or the pediatric trauma medical director and any provider who is or has undergone review by the alternate pathway. A lot of questions on the liaisons and non-liaisons, and I realize we've been programmed to have the liaisons have external CME, but we are no longer asking that. And again, I just pulled a couple of questions that were relative to these trauma centers. We did have more questions upon this, and they were all very similar in context. So again, I just wanted to pull a couple of those in. So CMEs are not required for liaisons and non-liaisons who maintain current board certification. External CMEs are only applicable to the trauma medical director or pediatric TMD and anyone who's undergone or is or has undergone alternate pathway. And I'm sorry I sound like a broken record, but I just want to make sure we were clear in covering a lot of these questions. Staying current with board certification, say 10 years, which is for the general surgeons, there's a difference for the other specialists with satisfied trauma call panel CME with the exception of the above, and that is correct. For level 3, CME requirements for level 3, I know there were some changes. CME requirements for trauma surgeons and ED docs. Is there a CME requirement for general surgeons taking trauma call at a level 3 facility? No, there is not. So level 3s are exempt from the CME. We are not asking level 3s to have CME at this time. Again, one of the requirements is that everyone, whether it's a level 1, 2, 3 adult and or pediatric trauma center, everyone who is seeing a trauma patient or taking trauma call must be current in their board certification. New trauma centers seeking verification. This is a great question. Is it only the trauma medical director that needs 12 hours of CME for the first verifying centers, or do all the other docs? Just the trauma medical director. So everyone else, again, has to maintain current boards. Trauma medical director for, again, first-time verifying trauma centers. New trauma centers are verifying for the first time. Only have to have 12 hours of CME. If they have more, that's great, but we're asking for 12 hours at this point in time. And again, just to clarify, if it's a new pediatric trauma center that's coming on for the first time to be verified, of the 12 hours, 3 hours must be specific to pediatric trauma. And again, this is talking about lifetime and board eligible or grandfathered providers and board eligible. We have a surgeon who is board eligible but not currently board certified. What are the CME requirements for him? Can you please explain what are the requirements for MDs who are grandfathered and do not have to renew their boards? Again, current board certification is applicable to the board eligible, that being recent grads, and lifetime, that being grandfathered physicians, surgeons. They are in compliance with the CME criteria. What are the new requirements for mid-level practitioners? Do they need 36 hours of CME over 3 years? No. Advanced practice providers, or PAs, if you will, are not required to meet the CME criteria, so we're not asking them to have CME. Same goes with CRNAs. We don't ask CRNAs to have CME. Are there new requirements for radiologists, for radiology liaison and the anesthesia liaison? There are no CME requirements for the radiology or anesthesia liaisons. There never were, and we are not imposing that at this time either. In addition to accepting MOC as CME evidence, is this sufficient for pediatric centers, or is pediatric CME still required? Again, we're not collecting or verifying MOC documentation, just maintaining their current board certification, whether that be in PEDS or in trauma, meets the CME or satisfies the CME requirement. Again, just the pediatric trauma medical director and or the trauma medical director has to have external CME with 9 hours being specific to PEDS trauma. Lab board certification. So we do not need to collect CMEs for anyone who is not a liaison to the trauma program as long as they are current in their board certification, or do we need to have their CMEs present for the site visit? This person is correct. Only have CME documentation aside for the TMD and the PEDS TMD. For all other providers, you do not want to collect or print a CME certificate. We want to save some trees, and we want to save you time in gathering all that data or all that documentation. Again, the requirement is that they all are current in their boards. So if you have anyone who has lapsed in their boards, didn't recertify for whatever reason, just allowed them to lapse and just chose not to recertify, that does not meet the criteria, and that will be cited as a deficiency. The April 2018 release of the clarification document indicates the VSC would accept 33 hours from boards, certification or recertification toward 36 hours. How is this 33 hours determined? Really, in level 1 and 2 trauma centers, what that really means is that if the trauma medical director or pediatric trauma medical director recertified within the 3 years leading up to a site visit, they can account for 33 hours of their board hours towards the 36, so they would only need 3 additional hours. So that's really what we need from those, for those instances, rather. Can you give examples of ongoing professional practice evaluation process that is now being required for emergency medicine, neurosurgery, orthopedic surgery, and ICU? Ongoing professional practice evaluation process is not a new criteria. It is listed under CD 5-11. I realize that the language is tweaked a little bit in the newsletter that we recently released, but there's no change to that. For examples of OPPE, you can go on our website and download some examples from there. Do the specialty panel members, emergency medicine, neuro, ortho, that are not a liaison still need to participate in the IEP if they are maintaining their board certification? If the trauma medical director, and I had talked about this a little bit when I first started talking about the CME, if the trauma medical director and specialty liaisons are expected to assess the individual surgeon's, physician's adequacy of trauma care knowledge in the ongoing professional practice evaluation process and retains the right to require additional CME or internal or through an IEP process, that will be based on their performance. And again, that is going to be imposed by the trauma medical director. If they see any issues with their performance or there have been any system issues, they can definitely impose that in addition to what is currently in place. I received the email regarding the change log pertaining to the external CMEs. My team, D, and I are hoping to get some resolution on this. Could you explain the latest update to the change log, specifically the external CMEs? Do the changes to the external CMEs eliminate the internal trauma-related CME credits? The change does not affect the CME type, whether it's external versus internal. The trauma medical director, again, PEDS, TMD, are the only ones that are required to have external CMEs. We do not accept internal CMEs for that or IEP hours for that. It has to be external And then I will say the IEP plays a role during the OPPE process, as I mentioned in the earlier slide. And that concludes our presentation for today. Thank you, everyone, for taking time to join us.
Thank you, Trauma Verification staff, and thank you everyone for attending today's webinar, Trauma Verification's May Q&A web conference. If you have any other questions, please contact cotvrc@facs.org. That's cotvrc@facs.org. On behalf of Trauma Verification and our presenter, thank you for joining us today and have a great rest of your day.